All right, so we're going to get started. Welcome, everyone. So this is going to be our first grand rounds for the year 2024. We are really excited about the year to come. Lots of different changes. We just had a meeting recently about maybe coalescing the grand rounds from the three academic centers and having a single grand rounds at a certain intervals, like 2 monthly or 3 monthly intervals. So more to come in that. And as we know that we are going to be the academic flagship for the health center and health system. And with that intent in mind, we're going to go ahead today with our first grand rounds, which is focused on a theme in electrophysiology. And before we get started, of course, we do our customary introductions to how do we get our CME and the MOC credits. So with that, you would have this link displayed at the website. And for the CME credit for the session, the number is 20393. For those who want to go ahead and do it now, punch the number now to the phone number 888-816-4893 as an SMS message, and you will be able to get your CME credit with that step. And if you are interested in the MOC point, it's the step 1. And after that, this link, which will be displayed again in the chat, you can use the barcode to be able to log in. And once you answer the MOC questions correctly, with the room code Future61, you will have your MOC credit directly credited to your ABIM ID maintained on the Cloud CME profile. All right, so with that, I am going to stop sharing my screen and bring on our grand round speaker, Dr. Tim Larson. Dr. Larson, welcome. And also I'm going to bring in for the grand rounds discussion, Dr. Will Costas and Dr. Shubha Gowda. They're going to join on for the panel session. And I'm going to briefly introduce Dr. Larson here. Dr. Larson, Tim Larson is Associate Medical Director of the Electrophysiology Lab and Assistant Professor at the Rush University Medical Center in Chicago. He completed his medical school from Michigan State University College, went in for internal medicine residency at St. John Provider Medical Center, later in Southfield, Michigan. Had his cardiovascular training at Virginia Tech, Carisian School of Medicine in Virginia, and subsequently had electrophysiology fellowship at VCU, Richmond, Virginia. He was the chief fellow in cardiology as well. At Rush, he has had a remarkable career as a clinician educator. He takes a lot of interest and has over 65 peer-reviewed manuscripts. His research interests are in complex arrhythmias and specifically in novel physiological pacing techniques, for which he's going to give us some insights tonight. And I wanted to mention also that his passion for teaching is evident. He was the Teacher of the Year at Rush in 2022. And he's also the assistant editor of Journal of Interventional Electrophysiology. With those things in mind, I think we are really looking forward to this talk. So Dr. Larson, thanks for sparing time today. I know that you have a very tight timeline on trying to be here, and we will make sure that we are positioning yourself timely so that you can go back and catch your flight in time. But we are really eager to hear your thoughts on physiological conduction system of pacing and the novelties that you're going to share with us. With that, the floor is yours, Dr. Larson.
All right. Well, thank you very much, Dr. Sengupta, and thank you all for your attention, and thank you for having me out here. It's been a great day getting to see the place and getting to meet everybody, and happy that I get to talk about a topic that I spend a lot of time thinking about, and that's physiologic conduction system pacing, which truly is a new era for cardiac pacing. here are my disclosures and my objectives, we'll touch on, we'll review the evolution of conduction system pacing briefly, then touch on some of the relevant pacing anatomy and physiology, and then the bulk of the talk will be on reviewing the advantages and potential future applications for conduction system pacing. So, why are we talking about this now? Why is this, timely? So, there was just this large guideline document published a few months ago specifically on cardiac physiologic pacing and with a focus on the avoidance and mitigation of heart failure. So we, for the first time, have a guideline document focused only on physiologic pacing. So more on this to come later in the presentation, but this really is a topic that, while it hasn't been around for very long, has really gained traction quickly. So first, a brief history, a brief background on pacing. So, pacing's been the mainstay therapy for bradyarrhythmias for decades. The initial pacemakers were the size of a table. This is a pacemaker from 1946. And you can see the technology has come a tremendous way in roughly 70 years. So right ventricular pacing has been the primary strategy to both improve survival and quality of life in patients with bradycardia or Brady indications. But, conduction system pacing isn't actually a new concept. So in the 60s and 70s, there was temporary conduction system pacing in animals and then in humans. And then as late as the year 2000, permanent hip bundle pacing in humans was performed and published on. And then more recently, in 2017, Weijing Wang and his group in China published the first case report of pacing the left bundle branch area, direct capture of the left bundle branch in Purkinje's fibers. So why are we talking about this? So in the early 2000s, the detrimental effects of RV pacing became very apparent with the publication of the MOST trial in 2003, which showed RV pacing burden over 40% was associated with increased heart failure hospitalization and atrial fibrillation. And then this was followed up by the PACE study, where patients were randomized to either RV pacing or BiV pacing, and RV pacing was shown to have worsening LV function heart failure hospitalizations. This effect is even worse in patients who already have heart failure, as we know from the DAVID trial in 2002, and more recently BLOCK-HF in 2013. So what are we talking about here? It's really pacemaker-induced cardiomyopathy. So if you think about how many patients have pacemakers, and of course, I'm sure I'm biased in that a large portion of my practice has pacemakers, but the incidence of pacing-induced cardiomyopathy is as high as 20%, so that's 1 in 5. So if you think about what happens with these patients, it's a large number of patients. Hopefully they have a cardiologist or an electrophysiologist that they see that picks up on what's going on and refers them for biventricular pacing or possibly conduction system pacing, as we'll get into. But a lot of these patients, if somebody doesn't recognize what's happening, that they have a high degree of RV pacing, they run the risk of living with heart failure from this. It's not a small patient population. And how much pacing is too much? So, this paper published by Keel et al. In 2016 showed that a RV pacing burden of arbitrary cutoff of 40% was associated with increased risk of cardiomyopathy. And based on this and data that I showed earlier, conduction system pacing actually first reached guidelines in 2018, where if in patients with reduced ejection fraction, but over 35%, so in that 36 to 50% range, if they're expected to have more than 40% pacing burden, it's reasonable with a class 2A indication to choose a pacing method that maintains physiologic ventricular activation, such as CRT with traditional body pacing or hip bundle pacing. This is, in 2018, is the first mention of conduction system pacing in guidelines. Now, we're talking about patients with pacing burden over 40%, but if you look at this this graph here on the right, actually a pacing burden as low as 20% also increases risk of cardiomyopathy. So overall, the take-home message here is RV pacing is detrimental. So let's take a closer look at the cardiac conduction system. So what exactly are we pacing here? So we know in sinus rhythm, sinus beats originate in the sinoatrial node in the, in the right atrium near the junction with the SVC. The signal travels through the atrial myocardium to the AV node, which is, located at the apex of the triangle of Cook. The AV node terminates into the His bundle, which is a discrete structure that penetrates the membranous septum and ultimately branches into the right bundle and left bundle. So we can pace in multiple locations along the conduction system, as I'll show you in just a minute. One of the technical difficulties is that instead of implanting a pacemaker where you can capture almost anywhere in the chamber, now you're targeting specific discrete structures. So let's take a look at what happens if we implant a traditional dual chamber pacemaker with a pacing lead in the right ventricle, often in the apex, or traditionally the apex. So unfortunately, when we do this, this leads to very abnormal activation. The signal travels inefficiently from cell to cell, and this leads to dysynchronous activation where whether it's the right ventricle before the left ventricle or the left ventricle septal wall before the left ventricle lateral wall causes problems. So we end up with a very wide, abnormal-looking, ugly-looking QRS, often fractionated. On the bright side, this is better than asystole. At least you have heartbeats, but only just. Now, what about for patients who need a lot of pacing, or perhaps more interesting, patients who don't need more heartbeats, but need relief from the abnormal activation pattern we see with left bundle branch block? Well, one therapy we can offer is biventricular pacing. We can put a lead in the coronary sinus and pace the right ventricle and pace the left ventricle lateral wall at the same time and improve outcomes. So this still produces a highly abnormal QRS, and this QRS really only looks good when compared to the terrible QRS of RV pacing. It's really kind of amazing that this works, because this is still not physiologic. There's several major problems with biventricular pacing. For one, your activation is never going to be normal. It's epicardial to endocardial, which is opposite of normal. You're limited where you can place that lead into only a few places per person that nature provides you, and your QRS is still wide, and LV activation is still abnormal. Well, as you can see here, if we put our pacing lead in and implant it in where we capture the conduction system, we can activate the ventricles over using the Purkinje network and produce essentially normal QRS complexes, which I'll show you here in a minute. So how do we do this? So I talked about this briefly a moment ago, but the entire His bundle is about 2 centimeters long, and it's a couple millimeters wide. So you can target this several ways. The His bundle exits the AV node, again, the apex of the triangle of Cook, at the location where the septal tricuspid leaflet connects to the annulus. You can map these signals, you can measure His bundle potentials, and you can fix your lead there. So these leads, especially early on, were often actually above the tricuspid valve, so the atrial side of the tricuspid valve. There's some potential benefits of this in that your lead doesn't interact with the valve at all, and you can actually implant these in somebody with a mechanical tricuspid valve. It's not easy to do, but it can be done. But as you can imagine, this presents a few limitations, which we'll get to in just a minute. And just in case you need more proof to believe me, I don't have a cursor on the main screen, but what you can see here, right atrial lead, and this is our His bundle lead. This is our tricuspid valve, coronary sinus here. So this lead was implanted for 3 years, and this lead is above the tricuspid valve. This lead is in the right atrium, but it's capturing ventricle. Here's a light in the left ventricular outflow tract. It's illuminating the membranous septum. So this, again, highlights this lead location, and it highlights that you're in the thin membranous septum. This presents a couple challenges here. Think about when you come to sensing, or when you think about thresholds. More on that to come. So here's histology from the same case. So we have the gross specimen on the left. You see the part labeled TV there. That's your tricuspid valve. And you can see where that lead is pointing, that little fibrous sheath. This lead is above the tricuspid valve, and it's attached to the membranous septum. It's not embedded in myocardium like a traditional pacemaker lead. So how do we find this site? So here's an example of tracing from our EP recording system. So it's 12 surface leads, standard ECG leads, and the bottom line there is our an intracardiac recording. So a unipolar recording from the tip of our pacemaker lead. It's at 100 sweep instead of the usual 25 sweep. That's why it looks like such a long PR interval and wide QRS complex, but this is a normal sinus rhythm. And what we see here is a far field atrial signal, a His signal, discrete His signal, and then a near field ventricular signal. So this would be a good location to potentially implant a His bundle lead. And if you do that, you can pace. This is right ventricular pacing. If you take the pacemaker spike off, you can't tell that this is a pacemaker. This is a patient with complete heart block and right ventricular pacing. So essentially producing a normal QRS. So that's great for patients with normal baseline QRS complexes, but what about patients with left bundle branch block? Well, here we have a case of a patient with a baseline left bundle branch block, and pacing, we can implant a pacemaker lead, and this is threshold testing. So we can normalize left bundle branch block, and we can actually have multiple thresholds. So here we have His bundle plus RV capture, so fusion, so non-selective His bundle capture. As we decrement output further, we have selective His bundle capture. And ultimately, right before, we lose left bundle recruitment. We're actually capturing only the right bundle branch now, and then loss of capture. So in this one lead, in this one position, you have 4 different thresholds to figure out. So it's a little bit more complicated, but it's possible. So there's benefits and risks with both traditional RV pacing and with His bundle pacing. So the benefits of His bundle pacing are that you prevent the development of catastrophic dyssynchrony in your patients, which may avoid pacemaker-mediated cardiomyopathy and LV dysfunction. You preserve not only AV synchrony, but intraventricular synchrony. And as I showed on that last slide, you can actually restore conduction through disease His-Purkinje system in many patients. You know, the downside of His bundle pacing, this is specific to His bundle pacing, is, you know, is one that is technically challenging. You're targeting a structure that's a couple millimeters with a catheter that you really only are guided by fluoroscopies and electrograms. The electrograms are critical to this. But look at, I showed this picture earlier. Look where that lead's implanted. You're not embedded in myocardium, as I said. So you risk ventricular undersensing. And if you look, this muscle tissue just above the lead, that's atrial myocardium. So you run the risk of atrial oversensing. And again, not in myocardium. You're in the membranous septum. There's issues with high thresholds. 10 to 15% has been published. It may be even higher than that. So, yeah, and you can even capture the atrium sometimes. We can sometimes make it even more confusing. The other issue is that we know these thresholds aren't stable over time, and thresholds can rise. So there's variably reported 3 to 7% lead revision rate. That may even be higher. So despite what you can do with His bundle pacing, these are major limitations, and these really limited broad uptake of this technique. Until around 2007, when again Weijing Wang in China developed the technique for left bundle pacing. So, you know, there's a lot. It's not a surprise this came from China, because there's a lot of interest in that country for, you know, the patients to get a device. They often are paying for it out of pocket. So the difference in cost between a biventricular device and a dual chamber pacemaker, just pulse generator, is like over $10,000. So, you know, for a cost standpoint, There was a lot of investment in this sort of thing at the time. So what he developed is he would implant the His bundle lead, and then he would initially he was trying to capture more distal His, where the His meets the muscular septum on the ventricular side of the tricuspid valve. But what he found is if you can actually implant the lead deep in the septum, and so this is, roughly where the septum starts. You implant the lead deep, you can get all the way through to the other side without going through, and you can capture the Purkinje fibers and the left bundle branch fibers that are on that side. So just to prove to you how deep this is, if you've seen this before, this won't come as a surprise, but this is a contrast injection through the delivery sheath. And you can see the ring electrode on this pacing lead is embedded in the septum. So it's roughly 1.1 centimeters from the tip to the ring. So this is over a centimeter into the septum. There, you can't see the septum on fluoroscopy without contrast, but that's roughly the outline of where it is. So you can imagine this picture on the left you've seen a couple times now. That's His bundle pacing. The picture on the right is an echo 4-chamber view of a left bundle lead. So this lead's now embedded in muscle. It's in tissue. So this lead behaves much more like a traditional pacemaker lead with low thresholds, with excellent sensing. You're not anywhere close to the atrium. There's no atrial oversensing. In follow-up, you can treat these very much like a traditional RV pacemaker lead. Whereas His, there's all sorts of problems, and they have to be followed in a center that has specific expertise in managing these to solve some of these problems. These patients, you can do this. If they go somewhere else, if they move to anywhere in the country, they can go to any device clinic, and the treatment is essentially the same. Follow-up is essentially the same. There's multiple studies that have shown the safety and feasibility of this for routine pacemaker implants. So there's several locations within the conduction system that you can implant these leads, as I've alluded to. You can implant in the proximal His. On the atrial side, that was the initial strategy. You can implant on the distal His. On the ventricular side, you have less sensing issues, but still have issues with thresholds. Or you can implant in the left bundle area. So proximal left bundle, deep LV septum, or left posterior fascicle. And the real benefit of this, the His bundle itself, again, small, discrete, narrow structure. The left bundle and the left posterior fascicle and anterior fascicles, they're fan-like structure. Now, this is a cartoon, but it shows the relative size of these structures versus the His. So you're targeting a much larger area. And so the way this is done is we'll map for the His, find that His location, or at least know where the annulus is, because sometimes you'll not see a His if you're, say, complete arc block, and then move roughly 2 to 2.5 centimeters in a line straight towards the apex in RAO view. Then switch to LAO view, which is over here, and that gives you an idea of your lead depth within the septum. So one concern with this technique is that if you're too high and if you're too anterior, you might not be on the septum, you might be in the outflow tract. So you can imagine what would happen if you put a lead a centimeter out the outflow tract. Where are you going to be? You're not in the heart anymore, you're going to be in the pericardium. So early on, this was a big concern, and people had a lot of anxiety about this because you're intentionally causing a perforation if you're in the wrong spot. The technique to deploy this is going to perforate if you're in the outflow tract. Is a concern. So, one way to kind of figure this out is to pace map the septum. So when you pace on the septum, you often initially get this W pattern or this notch QRS in V1. It doesn't have to be like that. It isn't always like that, but it often is. But more importantly, your AVR and AVL leads are discordant, and lead 2 is taller than lead 3. Lead 3 often has a negative component. So your pacing looks like a parahiscient PVC. If it looks like an outflow tract PVC, I wouldn't deploy the lead there. And actually, for a publication, I tried to make a figure of what this would look like, and you have to be so far anterior and so high that unless you're really confused, you would never think that that's where you should deploy the lead. But I'll say, I had one case where we pace mapped, and we had an outflow tract morphology, and we came back on the floor, our sheath had jumped out. So I think I think the chance of doing this by accident are pretty low. But, as we deploy the lead through the septum, what you essentially see in V1 is that notch moves more distally in the QRS until it almost is like it emerges out the back end as an R prime, and you have a right bundle branch block type morphology. And with some of the newer lead delivery equipment, you can actually see this in real time, where you don't have to disconnect and paste and test. You can connect your PSA cable in a unipolar configuration. You can paste as you deploy the lead, and you can actually see, look at V1 here. You see that notch in the middle that I showed you when you're on the RV septum. As you progress out, this is real time. This is the actual number of beats it took to do this. You can actually see that notch push out until at the end here we have left bundle capture and have a right bundle branch morphology. Now, it's not normally that quick, but with continuous pacing, you can demonstrate this. There's been a lot of criteria published on how to tell that you're capturing the conduction system. This is probably beyond the scope here. In the interest of time, I'll skip over this a little bit, but you actually can measure Purkinje fibers, and whether it's a left bundle potential or Purkinje potential is that's an ongoing debate, but you can measure this and actually have selective left bundle capture with this technique. So just briefly on selective versus non-selective. So selective capture is where you capture only the conduction system. You don't capture any ventricular myocardium. If it's the His, you have a perfectly normal QRS. If it's left bundle, you have a right bundle branch morphology. You have an isoelectric interval on your EKG, and you have a delay on your local ventricular electrogram, because you're not capturing a local. You're capturing the conduction system, conducting down the conduction system, and then conducting back up to your lead. So if you think about it, there's no other way you can have a delay in your local electrogram unless you're not actually capturing the local tissue. So you have to connect the capturing conduction system. This is important, especially as I'll show you in a minute, with left bundle pacing, because this proves that you're capturing what you think you're capturing. And so here's an example of selective His bundle capture versus non-selective, where you have a pseudo delta wave and you don't have that delay in your local ventricular electrogram. And again, you have that pseudo delta wave. You have the same thing with left bundle. It's less, you see it much less frequently with left bundle pacing. And that's simply because your lead is implanted in myocardium. So if you see a difference in your conduction system threshold and your myocardial threshold, it's almost always right at threshold, or just a little bit above threshold. It's most important for confirming that you have capture, because if you have this change, either way, select it, non-selective to RV only or non-selective to selective, you proved you're capturing conduction system. With His, it's a much bigger deal because the thresholds can be wildly different. But with left bundle, we see the same thing. So here's non-selective to selective. So you see it during threshold testing, usually when you get close to threshold. If you look at the morphology in V1, you see you lose that delta wave and you have more of a pure right bundle branch block pattern. But importantly, if you look at those circled electrograms in the bottom, you see the delay in your local electrogram, and that proves it. Just another example of selective, again, non-selective to selective. So if you look at the very bottom, you see that delay, and again, it's just it's confirmation. Briefly want to comment on anodal capture, because your ring electrode is actually touching the septum, but often it's not, I doubt it's ever going to be the whole ring. It's often just the tip of the ring. So you can possibly have anodal capture. So this just throws a little wrinkle in here. You can have loss of anodal capture, you can have loss of RV, and then have non-selective left bundle capture, and then loss of RV capture and have selective. So you still have multiple thresholds. So if you're looking at these, if you're ever doing this, there's a lot to watch out for, but it makes sense. So the one thing about anodal capture is it's generally at high outputs. So the main thing here is for the future electrophysiologists in the room, just because you see a morphology change, if your pacing output is 5 volts, it's probably anodal capture. It's not confirmation of left bundle capture. So that's great for patients' normal QRS. So if we show that we can normalize a left bundle branch block pattern or recruit the left bundle or correct left bundle, what about using this for cardiac resynchronization therapy? So this is CRT with bi-V pacing is a well-established therapy indicated for patients with heart failure with reduced ejection fraction and left bundle branch block. We know that patients can respond to this, their EFs can normalize, they can live longer. But there's problems. About approximately 17% of patients who are referred for biventricular pacing don't receive the intended CS lead for one reason or another. But even more concerning, of those that do, about a third are non-responders. So what options do we have for these patients? We can send them to surgery and have a surgical LV lead that also has problems. It's not an easy area to get to. You know, it's surgical dependent and it's a surgery. So the real question, the underlying question here is, can conduction system pacing reverse the detrimental effects from a left bundle branch block? So I already showed you this with His bundle pacing. You can recruit the left bundle with His bundle pacing. Here's a patient with a left bundle branch block at baseline. Here, this is now the same patient with a narrow QRS with a left bundle lead, non-selective left bundle capture. So certainly you can recruit the left bundle with this technique as well. You know, it's not necessarily going to work in everybody. This was a really nice paper from the University of Chicago group. And what they did here is they put a multipolar catheter in through arterial access across the aortic valve to measure Purkinje potentials on the left side of the septum. And what they showed here in the first panel is normal activation. So proximal to distal, His, when there's still an A signal on there, it's His, then left bundle, down to distal Purkinje. So the middle panel shows a patient with a wide QRS complex who still has, it's a left bundle pattern wide QRS complex, but they still have all of those Purkinje potentials. So what do you think, if you implant this lead and you can capture somewhere along the septum, do you think you'd be able to recruit the left bundle in this case? And probably not, right? So you either, now we don't know where the site of block is here, right? Because you see potentials all the way down, but you know the site of block is more distal than that. Is it diffuse exit block out of the Purkinje system, or is it some sort of interventricular conduction delay? Either way, these patients, you're probably not going to be able to recruit the left bundle on. Now, how about this last one, this last panel? You see what, you know, the UFC group called left intrahischian bundle branch block. So you just lose Purkinje potentials. Now, we have to trust that they tried really hard to find them and that they're truly not there. But in this situation, if you can implant the lead and capture Purkinje fibers more distal, you may be able to recruit the left bundle, as they showed. So when the site of block was in the left when the site of block was within the His itself, the QRS corrected 94% of the time, most of the time. When it was more distal left bundle, they were able to correct it 2/3 of the time. But when you had that middle panel from the prior slide, when you had intact Purkinje conduction down the septum, in that scenario, they were never able to correct the left bundle with conduction system pacing. So that was about a third of patients. So, you know, this is important. This suggests, you know, this is a fairly small study, but if these numbers hold true for the larger population, roughly a third of patients with a left bundle branch block morphology, you wouldn't be able to correct with this, but close to 2/3 you can. Problem is there's no real way to know that before. They tried to see if there are any EKG criteria to predict this, and there was nothing else predictive. Maybe somebody will develop an AI algorithm to figure that out one day, who knows. But, you know, for an initial therapy, there's very good data to support biventricular pacing with a traditional LV lead. So you can't just, from a ethical, clinical equipoise standpoint, you can't just start implanting left bundle leads off the bat. But so our early experience with this, and we published from our group, and we were part of this study, was looking at patients who failed biventricular pacing. Either you weren't able to implant an LV lead, or they were non-responders. And what we found was that in both groups, that we were able to convert a large number of non-responders or patients who couldn't get CRT to responders. So this means this is showing improvement in ejection fraction. And I showed you slides like this already, but this is one of our patients with a left bundle branch block who has non-selective to selective left bundle pacing and with normalization LV function. So there have been some interest in randomizing patients to initial therapy for conduction system pacing versus biventricular pacing, and an initial small, albeit small trial with 40 patients conducted in China, randomized patients to left bundle versus CRT, and showed equivalent outcomes, actually slightly favorable outcomes for the left bundle pacing arm. But again, small study, it's a pilot study. But based on this and some of the other studies, this led us to this 2023 guideline that was published a couple months ago. How are we on time? We're coming close to time, so I'm going to go over this algorithm. I know every Grand Rounds talk is always improved by adding complicated algorithms and giving people a few minutes to try to figure out what's going on here. But we could talk about each of these limbs, but what I want to highlight here are how many of the limbs end with conduction system pacing as an option, with either a 2A or 2B indication. This is for patients with Brady indications. So this is your non-heart failure patients. So if your patients are, and if you focus towards the right, the circle towards the right of this algorithm, and follow this algorithm down, anticipate sustained pacing? No. LV ejection fraction over 50%? Yes. You now have left bundle branch area pacing as a 2B indication for upfront therapy for routine pacemaker indications. If we look at patients with heart failure, it's a little more complicated. There's still preference for traditional biventricular pacing in the majority of indications, but we still see conduction system pacing showing up here in several areas, including ineffective CRT, with a large section being patients with ineffective CRT. So where do we stand now? So the strength of evidence for CRT and left hip bundle pacing and left bundle pacing is that we have large multi-center randomized trials showing favorable outcomes for CRT with traditional LV pacing, with improvements in many metrics, hospitalizations, LV function, and mortality. With conduction system pacing, we have a lot of observational data and some small randomized trials. So that leads us to talk almost to the end of my talk. I want to spend a moment talking about the left versus left trial. So we know a third of patients with biventricular pacing won't respond. So CRT is not perfect, but this trial is enrolling a target enrollment of over 2,000 patients, 65 centers in the US and Canada, and patients with any indication for biventricular pacing or for CRT are being randomized 1-to-1 to traditional LV lead versus conduction system lead. So we're one of the 10 early sites for this trial. So this trial started enrollment in October. We've done several of these cases. So it's going to be a few years before we have the results from this trial, but it's ongoing now, and this is the first multi-center, large-scale randomized trial in conduction system pacing, and we eagerly await the results. I've done about 4 of these cases, and it's been working so far anecdotally. So just to summarize here, the clinical utility for conduction system pacing is this is a feasible approach and may be superior to RV pacing for routine bradycardia indications. I implant conduction system leads as my first line approach in almost everybody who has a pacing indication. But you can also correct wide QRS complexes, particularly keep in mind that cardiac resynchronization of 5V pace is not always possible. It's not always feasible, it's not always possible, and it doesn't always work. This gives you, at the very least, a second option. Potentially one day down the road, it could be a primary strategy. Now, I don't think biventricular pacing I don't think that's going away. I showed you data, prior slide, about a third of patients have diffuse distal Purkinje disease or intraventricular conduction disease, something like that. But this gives us options. And I didn't talk about special populations much, but this is a nice technique for patients. If you imagine a patient that may have a normal QRS or mildly reduced, or may have a normal ejection fraction or mildly reduced ejection fraction, you're about to do something that's going to make them have a high amount of RV pacing. Conduction system pacing allows you to maintain normal activation. So one example is, a patient with atrial fibrillation who end up with needing AV node ablation. This gives you a nice option. So that's what I have today. I'd be happy to take any questions.
Thank you,
What
Dr.
Chicago looks like not in January.
Thank you very much. Thank you very much. So I think we have had a packed audience to your talk. So we have over 30 people online, and the room is also packed. So without further delay, I'm going to invite both Dr. Costes and Dr. Gowda to make their commentaries. Dr. Costes, first, if you would like to go.
Sure. Tim, that was a terrific review of conduction system and conduction system pacing. We had some time to talk today, and as we discussed, it's really gratifying. I had a patient last week who came in a complete heart block, and as they say, it's better to be lucky than good. But with the delivery sheath, I managed to find a good place pretty early on. First place I deployed, his QRS is 96 milliseconds, and I think he's going to do very well despite 100% burden of RV pacing. This is, of course, in a patient without pre-existing conduction system disease, and I was wondering if you would elaborate a little bit more on what you think might be future options for people with distal conduction system disease in the left bundle. For example, if left bundle branch area pacing doesn't work, would you then intra-procedurally go look for a CS lead position, or what would be your theoretical approach?
Yeah, so I think if you're doing it for CRT or cardiac resynchronization therapy, I think that's important. So there hasn't been anybody that's published on a reliable, validated way to determine this pre-procedure. So, about a third of the time you can't capture conduction system. In those cases, I think you need to be ready to implant the traditional CS lead.
Yeah, and I guess
And
probably the first question I should have asked is the flip side. When you don't have an appropriate, posterolateral branch, or it's too tiny, or you can't get avoidance of phrenic nerve capture even with a quadrupolar lead, how often are you now using left bundle area pacing as a bailout rather than sending somebody for a epicardial lead?
I've done it. The published literature is 10 to 17% range. And, there's other things you can do. As you know, you can put a lead in like the AIV, which isn't going to provide resynchronization, but I'll leave a lead there and it'll look like there's a biventricular device on X-ray. So before doing that, I'll map and try the conduction system, and sometimes after 4 hours in the CS, we do one deployment with a conduction system lead, and we have a narrow QRS, and you think, why didn't I do this 2 hours ago? And there's definitely those cases. And I think in the moment, I think that's where we are with this technology for CRT applications. Once we have more randomized data, particularly we're excited about the left versus left trial, I think that will answer the question on whether or not this is a viable upfront strategy.
Yep. And I guess my last comment before I turn things over to Dr. Gowda is kudos on the left versus left trial, because as you didn't have time in your talk, but for the fellows, if you look at Heart Rhythm last year, there were the two Geisinger trials. There was one randomized trial, I think it was only 100 patients, and there was sort of a registry trial of It was 1,800 patients or so, suggesting that left bundle branch area pacing may be equivalent-ish or possibly slightly superior to CRT, but we don't have a really big randomized trial. And what you're proposing to do and have now started enrolling for in left versus left is really great, and it will be important to the field.
Shiba.
Oh,
Did it-
thank you.
Yeah.
Thank you, Dr. Larson. It was a very elegant presentation of a very challenging and cumbersome physiological pacing, which is really the innovative and probably going to be the primary mode of pacing at some time to come, although it is extremely limited by operator dexterity and experience. So a lot of congratulations on all your trials, your publications, especially the most recent one in November, quite salutary effects on all the physiological pacing. So congratulations on all of that. I have a few questions. The first one would be simple. How many PIV patients with a CS lead who are non-responders have you brought back to the lab to do physiological pacing?
So I don't know how many I've done personally, but we've done a handful. And this is always the question, if the ejection fraction stays the same. So the patients that where this comes up are patients where the ejection fraction doesn't improve and they're worsening.
On their class of.
Yeah, exactly. So, and I showed briefly the data from Rush and Geisinger that we can improve the ejection fraction in these patients. Now, over 50% at least, were unsuccessful LV lead deployments where the decision can be made intra-procedure. So that's a much easier situation. I mean, I think there's almost certainly, I don't know this, I don't have any data to point on this, but I think almost certainly there's a larger population of non-responders or under-responders who could potentially benefit from this. It's hard to define, and you probably need a protocol and IRB review, because what you're talking about is doing another procedure that they wouldn't have had otherwise. Now, there may be benefit to that, but I don't think I wouldn't necessarily recommend that as a routine strategy, but for patients who don't respond, especially if they're worsening clinically, we've done it, and we've actually had some anecdotally really good success stories. And
that's something to think of, especially for the non-responders who you think that their only choices are an LVAD or end stage, and they don't have many bridge options. So that was very interesting. My second question is, the challenges of physiological pacing are A, experience-driven, and B, for especially those complete heart blocks. Have you, dislodgement is a real issue, challenge, procedure time, dexterity is a real issue. Mainly the dislodgement is the biggest concern. How comfortable, I'm sure you're probably a lot more comfortable, but in the smaller centers and the people with a lesser experience, to do the left bundle or the his bundle pacing on a complete heart block patient who has no underlying rhythm, what are the challenges and what are your thoughts?
Yeah, that's a great question, because this especially comes up if you tried his bundle pacing 5 years ago. His bundle pacing is technically much harder. You're, again, targeting a discrete structure that's a couple millimeters wide, and the leads are less stable. We know that. That's well known. Left bundle pacing is different. So you implant this lead, and it's embedded in myocardium. You test it like you test a traditional RV pacing. You see, you can watch your, this is a little more technical than I got in the talk, but you can watch your impedance changes as you deploy the lead, and you know when you're getting close, and you know when you went through. And if you have any concern, you can pull on it a little bit. If you're through, it comes right out. If it doesn't, you can feel.
So is it safe to say that you would steer away from his bundle completely and just aim for left bundle? Because your paper says 3 to 7% dislodgement rate, but in real life, I believe it's a lot more. The 3 to 7% is in
I
larger
agree with you.
institutes with much higher experience.
I think that was lead revision rate. So I think, I personally think
I
the
meant
lead
the lead
revision rate is
revision.
higher as well. And, but that's what's been published. But, yeah, it's rare that I have implanted a HIS bundle lead within the last 5 years, a handful. So I've done it in non-complete heart block, where we had, excellent HIS capture with no oversensing issues and good thresholds. So that's rare. To the point where I don't deploy the lead in the HIS anymore. I map for it as a marker for where I end up deploying in the left bundle area. But left bundle solved. The moral of the story is that left bundle area pacing solves many of the major limitations from HIS bundle pacing, mainly the technical issues, the threshold, the lead stability, and sensing issues.
So I think I just want to bring a very important question. In the scale of events, and particularly when you're having a multidisciplinary approach to patients with end-stage heart failure, and particularly also now since many patients with LV dysfunction with failed CRD starts having severe mitral regurgitation, you're thinking about clips. It's a very involved discussion of what all can be done. And I've very frequently had heart team conversations where we really don't think about the electrical aspects of how we could do some reversal of remodeling and maybe eliminate their mitral regurgitation. And now hearing that maybe we should think about revising some of the approaches and see if it's something could improve the failure of the CRD in some of these patients is very important to bring back onto the tables to some of these end-stage patients. Because even if you can increase ejection fraction by 5-10%, a lot of these new therapies or new trials are demanding 20% or less. I think they are excluded. And
Involving the heart failure team very closely and having them understand the physiological pacing is very important.
Very important. And so I think I feel very intrigued by what you have presented, Tim. I also feel, I mean, this is a lot of discussion beyond it. I mean, this is the electrophysiology, a little electrophysiologist inside me of whatever I've done of physiological and why does the heart actually have a His-Purkinje system? And, my perspectives are that there is a flow rheology component of how the blood is moved from systole to diastole through vortexes. And I've done some work and some animal work where we have shown that aberrant electrical activation destroys the flow sequences and the normal hemodynamic courses. I mean, there's much more beyond that. But maybe in the future, I've heard about multi-site LV pacing. Maybe we do it from the epicardial side. Or I've thought about this innovation inside me of implanting multiple small beads of piezoelectric crystal driven, which can be externally be driven to create local electricities. And you could, I mean, I'm having all of kinds of thinking, and you're really making me think beyond the boxes. But kudos to you for a lot of different things to think about.
It may be possible to implant a piezoelectric crystal with an electrode on the left side of the septum and capture the left bundle that way.
Yep. Anyway, so I know that you have a flight to catch. And Shubha and Will, if you have any other last burning question that you would like to address,
I'm good. Thank you very much, Dr. Larson.
Yes.
I think there was one in the chat actually from Dr. Maganti.
Yes, Dr. Maganti. And I can read, at this time, can you identify non-responders from responders in those with narrow cures for BIV pacing prior to bringing them into the lab? Good question.
We wouldn't. Oh, I'll let Tim answer. But we wouldn't typically bring people for BIV pacing if they have a narrow QRS because echo CRT showed that was not beneficial.
I mean, it'd be great if we could, if we could predict. Well, here's the thing. So the paper from University of Chicago was very elegant, but it was somewhat crude. They just put an electrode on the left side of the septum, and they tried using different Strauss criteria and other criteria for predicting typical left bundle branch block, and they weren't, albeit a small sample size, they weren't able to come up with any ECG predictors that would predict, distal Purkinje disease or IVCD that looks like a left bundle. They couldn't. Now, if you had it, could you do that some other way with,
So Tim, here's an idea to do it.
Possibly.
Dr. Larson, here's an idea to do it a different way, because definitely we can't and wouldn't bring the narrowers. But for a trial and for an academic institute like you, if you just do a transeptal, map the LV, find the areas of scar where the most delayed activation is greater than 70 milliseconds, or find the areas of scar and try to find the most latent activation, and then place the epicardial leads there, that could be a trial. It just requires a short LV map, which is not very cumbersome. If you think of
Jagsing
it.
and some others have actually done some of that work, and with multi-ventricular leads, and
Yeah,
hasn't been
it gets
especially
to a
effective. Yeah.
difficult area.
No, there's been a lot published on that, actually. There's even using the vest, electrode vest to show that where your latest activation is, but, it hasn't, the problem is that, I don't know it hasn't panned out. I don't know if it's a surgical approach, or it's not always easy to get to the basolateral wall through a surgical approach either, but.
Oh, actually, in the last 1 or 2 minutes, don't break an NDA if you've signed one, but at least one of the major vendors, and I suspect all of them, have talked about kind of the convergence of leadless pacing devices and conduction system pacing. Where do you see that going, or at least tell us what you can tell us?
I was wondering if that always comes up, because these are the two competing innovations in pacing. I was wondering if we were going to get to that today, and I guess what I can say about this is I have signed non-disclosure agreements with several companies, and there's prototypes out there.
Yep. Okay.
There's patients that have been implanted with these prototypes.
Yeah, there are
With
trials.
multiple companies, at least
So
3 companies.
I think I just sense a high degree of innovation in this area, and I think this dialogue needs to continue, and we really look forward to having you back, Tim. Wonderful. And with that, thank you all for joining, and have a safe flight back home.
Great,
Thank
thanks.
you for having me.
Thank you very much.
That was terrific. Thank you.
Thank you.
Quick question, Dr. Laura.
Yeah, of course.
For these patients in your